Hi everyone, I want to talk about acute bronchitis. And today I'll be talking about causes, symptoms, diagnosis, differential diagnosis, and treatment. In case you've had acute bronchitis in the past and your doctor has not prescribed antibiotics and you're offended, you're upset, the doctor doesn't know what it's doing, or blah 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 blah, don't worry. Just sit back, spend a few minutes, get yourself fully educated, and you'll be able to help somebody else. And if you are a nurse or a medical student, everything you need to know for exam or for any reason as far as acute bronchitis is concerned is here. Okay, let's go. Acute bronchitis. That is to say, there will be chronic bronchitis, right? To those who are not in the medical field, I know some of my friends in those days when they hear acute, they think that is the lesser problem. But when they hear the word chronic, like chronic bronchitis, they think that is more serious, right? Have you ever thought like that? If you're not a doctor, you're not a nurse, you've thought that chronic bronchitis is more troublesome compared to acute bronchitis, right? I don't blame you. Okay, acute bronchitis is very common. And the word acute means it is recent, it is sudden, or is happening just right now. Okay, chronic means it has stayed for a long period of time. Okay, but it is acute, it is recent, it is new, it is happening just now, but the cough could be for a long period of time. May or not have sputum production, so it could be dry cough, but it could also have sputum or phlegm. Could last 1 to 3 weeks, mostly due to viral infection. That is not to say it cannot be caused by bacteria. Don't worry, don't be in a hurry, okay? Inflammation of the lower respiratory tract is the cause, and the lower respiratory tract here will be involving the bronchi. That is why it is called bronchitis, inflammation of the bronchi. For you to be told that all you have is acute bronchitis, it means they've ruled out pneumonia. So no evidence of pneumonia, and you are not dealing with chronic obstructive pulmonary disease, which is going to be caused by either emphysema or chronic bronchitis. Okay, so no doctor will make the diagnosis of acute bronchitis in the face of COPD, because the component of COPD that could be related to bronchitis would be chronic. In that wise, it's going to last for at least 3 months, not 1 to 3 weeks, 3 months in the last 2 years. Epidemiology of acute bronchitis is occurring in about 10% of all clinical visits. It is more in late fall and throughout the winter period. So you are dealing with something like September, October, November, December, January, February, March, and maybe middle of April. Incidence is directly proportional to viral peaks. So the time that we have more viral problems like November, December, January, maybe February, that is the time that bronchitis will also be up there, because it's caused incidentally by virus most of the times. So causative agents right now, and to those who are not in medical field, this is the reason why you were not given antibiotics, okay? 60% will be caused by viruses, either influenza A or B, or parainfluenza, coronavirus types 1, 2, 3. I know everybody's familiar with that. I'm not talking about the one from China right now. Rhinovirus, respiratory syncytial virus, human metapneumovirus. All these could cause acute bronchitis. Coronavirus Novel coronavirus, the one from Wuhan in Hubei province in China, also causes cough. So I'm not ruling it out. Okay. So just alluding to the fact that many people will be familiar with that right now. 6% could be caused by bacteria. For example, Pertussis, Bordetella pertussis, Mycoplasma pneumonia, or Chlamydia pneumonia. What are the clinical features or symptoms? The first thing and the common thing will be the common cold, associated with headache, runny nose, nasal congestion, and sore throat. The cough could last 1 to 3 weeks, like I've said earlier, but the average period is 18 days. The cough could be dry or will have non-purulent sputum or have purulent sputum. There's possibility of wheezing or difficulty breathing. Remember, in medical school it is said not every wheezing is asthma, but all asthma will wheeze. Even not all asthma will wheeze because there's what you call silent chest in acute asthmatic attack. That is a very bad sign that the asthma is about to lead to respiratory failure. The affected individual is about to die. When wheezing has gone down, don't celebrate that you're not picking wheezing. You have to run fast in acute asthmatic attack with silent chest. Bronchi will clear off. What do we do to clear it off? While auscultating and we pick wheezing and want to rule out bronchitis, we just ask the patient to cough. And on coughing, the wheezing will disappear. 40% will have decreased forced expiratory volume in 1 second. Bronchial hyperactivity that has caused the wheezing will resolve in 6 weeks. Chest pain will be prolonged with coughing. That is normal. You know, everyone who has experienced coughing in the past, sometimes when you cough, you feel pain along the chest region, front and back. Still on clinical features, if the chronic bronchitis is associated with pertussis, the cough will be paroxysmal in nature. That is, it will be short outburst and frequent. There will be inspiratory whoop, and after coughing, that is post-tussive, there will be vomiting. It will be associated with pertussis outbreak. But the question is, what if this person is the first person to be diagnosed with it? The outbreak is not yet pronounced in the community, right? But good doctors will know that paroxysmal cough with respiratory whoop and post-tussive vomiting is associated with pertussis, Bordetella pertussis. And yes, like I just said, may not be associated with outbreak because the patient you are dealing with might be the first person, and with that be spreading further. Then anyone presenting in a similar way, the diagnosis will be easier to make. But it might be the first doctor to pick the first pertussis in your community. If it is associated with fever and chills, well, you should be careful because it should not be associated with fever and chills. So fever and chills should be absent. If it is present, if fever is present or chills are there, then consider something else. Are we dealing with pneumonia or influenza? If you pick signs of consolidation, that is, if you pick decreased air entry, dullness and percussion, when you auscultate, you pick bronchial breath sounds everywhere, pick a gophony, whisper pectoralicule, then that is bronchophony when you pick bronchial breath sounds everywhere. If you are able to pick all those, then you are dealing with consolidation. Then you should know this is beyond the bronchi. Okay, that will force us to do what? Chest X-ray. because we are dealing with pneumonia then. Still on clinical features, we have to distinguish certain clinical features to be able to come down on particular causes, particularly Chlamydia pneumonia will have no specific features, but you need to find out, do we have outbreak around? In case of Mycoplasma pneumonia, though there will be no specific features just like Chlamydia, but it is more likely that there will be outbreak around. In case of Bordetella pertussis, the cough will be greater than 2 weeks, or sometimes you don't find obvious cough, but if the cough is present, it will be paroxysmal in nature, associated with inspiratory whoop and pertussive vomiting. So you have to trace the source. You have to trace the contact person through which they've acquired Bordetella pertussis. Because we don't have it now very common around again because of vaccination. Influenza virus during flu season, right? Or recent travel to region with flu, there will be associated cough, body and joint pains, acute fever and chills, and then you know you are dealing with influenza virus. But remember, the flu can then give secondary bacterial infection, most of the time with Staphylococcus aureus. How do you make the diagnosis? Most of the time, acute bronchitis is clinically diagnosed. You can do your physical examination and look for signs of concentration, like I said earlier. Then, if you have done the first, that is clinical examination and history and everything, you have done that to exclude pneumonia. If you are still not comfortable, you can do chest X-ray. It should be normal or non-specific. And you might see lower lobes bronchial walls thickening. But to go home and sleep that this patient is not having pneumonia, then none of these must occur at all. There must be no hemoptysis. There must be no dyspnea, no fever, no immunocompromised status, no dementia, no tachypnea, no rales, no consolidation, no altered mentation, and there should be no decreased oxygen saturation. If you are able to see all those to be out, none of this is present, then you can bet your neck. It is not likely that this is pneumonia. Still on diagnosis, if the patient could expectorate and you have sputum, do sputum MCS and gram staining only if you are suspicious that you are dealing with influenza, or this patient is hospitalized, or you are dealing with health caregiver, or you are suspicious of pertussis. Or if you think you are unable to rule out pneumonia, then carry out investigation using gram staining of the sputum, microscopic culture, and sensitivity. You can assess the procalcitonin under certain conditions where timely manner results are possible, and that will help you to establish whether or not this is bacterial in origin or viral. And that will even help you further to predict the efficacy of the antibiotics that you have administered, if at all you have administered one. I have made a separate presentation on procalcitonin. Google that, check my channel for procalcitonin. You're going to find details. I think I have 2 presentations on procalcitonin alone. What are the possible differential diagnoses here? The first thing to consider is this pneumonia? It's possible. Post-nasal drip syndrome, gastroesophageal reflux disease, asthma. No, check my channel for pneumonia, for gel, for asthma, And are we dealing with ACE inhibitor, angiotensin converting enzyme inhibitor, because they give dry cough, particularly captopril? Are we dealing with heart failure here? No. Utopnia, paroxysmal notional dyspnea, cough, particularly when there's congestion of the lungs. I'm going to deal with cough there. Is this pulmonary embolism from DVT? Are we dealing with lung carcinoma? Or is this just smoker's cough? Because smoker's cough is for a long period of time as well. Lung CA, pulmonary embolism with tachycardia, tachypnea, acute onset, sweating profusely, and so on. Just ruled all other things out, not just, hey, acute bronchitis and go home. No, we don't do that. Treatment. When you have ruled out everything and you're sure it's not pneumonia, it's not heart failure, it's not all those things, then don't worry. Just advise, because it's going to be self-limited most of the time. Self-limiting situation. You educate that, oh, this call that you have presented with today is acute bronchitis based on my findings. So it's not what will go away in the next 2 or 3 days, my last up to 3 weeks. That's the bad news. You don't want to hear that, but that is the truth. So that the patient will not be going from one doctor to the other thinking that you don't know what you are doing. Tell the patient what you can give and what you cannot give. Because most patients will want to take antibiotics, right? And why are you not going to prescribe antibiotics? You should tell them 60% because of viral. And if it's antibiotics, the futures are going to peak. You have not peaked in this person, then you just tell them the truth. But I'm not going to let you go without giving you some stuff. You can have some lozenges, take hot tea, have honey. If you are smoking, stop smoking. Let's go over smoking cessation. You can check my channel in the next 1 week. There will be a detailed lecture on smoking cessation. You can have dextromethorphan or guaifenesin, but be careful if you are giving dextromethorphan to someone on selective serotonin reuptake inhibitors. Just find out, are you taking any antidepressant? If the answer is yes, then can I have the name or can I see the type you're taking? So for wheezing, well, can give you Ventolin. And for common cold, you just have to give Tanolol. Tanolol in some parts of North America, Canada specifically. I mean, I don't know whether some parts are also taking in paracetamol. In America, acetaminophen is the generic name. You can give your non-steroidal anti-inflammatory drugs, ibuprofen and the rest. Nasal cromolyn sodium, intranasal impratropium could be used to handle the common cold. That is, you are treating symptomatically since you have not diagnosed bacterial infection. In case you are dealing with bacterial infection, either because of high index of suspicion or because of the outcome of clinical features, examination, and the rest, and microscopic caution and sensitivity, we can give you empirical antibiotics before the result of microscopic caution sensitivity. And when the microscopic caution sensitivity is out, then give the specific antibiotics that the causative agent is susceptible to. It is not necessary to use antibiotics in influenza, that is in flu, but it would be nice. Sometimes you can be dealing with secondary bacterial infection. So if you suspect that, there's no harm. You can use antibiotics in hospitalized patients as well. Oseltamivir, that is Tamiflu, or zanamivir, that is Relenza, could be used in patients with flu. But of course, it has to be within the short time that the situation occurred, right? Then, of course, when it comes to follow-up, you can say, okay, see me again the next 2 weeks, or see me if you are having fever, chills, you understand, or vomiting, or you are becoming weaker and weaker, just come back immediately. Then you would have given all those symptomatic treatment measures. With that, because I expect recovery to occur within 1 to 3 weeks. So if the patient is not developing any problem and the recovery is not there after 3 weeks, we need to reevaluate again. And with that, I come to the end of this presentation. Kindly subscribe to my channel so that you can get all these presentations immediately they're published. I appreciate it.